Good evening and thank you for joining us today to this sixth episode of Filling the Lacunae, an initiative of Lalita Memorial Hospital, Rewari, in association with Rewari Obs Gyn Society, supported by Indian Fertility Society Haryana chapter, with academic partner Naari division of Jagsonpal Pharmaceuticals, makers of LycoRed-M, Divagest, and EndoReg. Jagsonpal are delighted to present Divagest, our range of natural micronized progesterone 200 SR, 300 SR, 200 soft gels, and 100 injections. Today's program moderator is Dr. Seema Mittal, Director, Lalita Memorial Hospital, Rewari, past President, Rewari Obs Gyn Society, and Treasurer, Haryana Indian Fertility Society. My request, Dr. Seema Mittal ma'am, to kindly initiate this session.
Thank you. Thank you so much, Anuji. And good afternoon, friends. Welcome to just another learning series that's Filling in the Lacunae, episode 6. Friends, learning is a continuous process. And it's a great moment for us when we have most devoted and level-headed teacher, Dr. Bela Bhatt. Some people really teach from heart. And it's a good tuition for all of us. So I will just request our chairperson, Dr. Reshmi Banerjee, to introduce the most efficient teacher for today evening, Dr. Bela Bhatt. Over to Dr. Rashmi.
Yeah, thank you, Dr. Seema Mittal. And it will be a pleasure to introduce Dr. Bela Bhatt to this august audience of this webinar. So she's done her MBBS and MD from Baroda Medical College, my alma mater too. And she's at present the chairperson of the FOGSI Imaging Science Committee 2021 to 24. And she has been doing a wonderful work as a chairperson and conducted many useful webinars. And I know it is a dream that every gynecologist should have a sonography machine and should be efficient enough or knowledgeable enough to do their sonographies on their own. I'll not waste further time to go into all our accolades, and we'll move over to the academics. Thank you.
Thank you so much, Reshmi. She is a dear friend of mine. We have studied together in Baroda Medical College. And of course, Dr. Seema Mittal, who is a dear friend and who is the force behind this entire series of webinars that has been happening. This is the sixth episode of it. And as a chairperson for the Imaging Science Committee, I take immense pleasure in continuing this work, which is done by Dr. Seema Mittal. I'm also thankful to Rewari Society President Dr. Alka, Secretary, and all the office bearers for this continued support. And of course, the FOGSI office bearers, President Dr. Jaideep Tang, Secretary General Dr. Madhuri Patel, my VP in charge, Dr. Giri Javag, and today's guest of honor, Dr. Charmila. Our chief guest, Dr. Jaideep Tang, and our guest of honor, Dr. Charmila, who is Vice President FOGSI, will join in between because there are multiple webinars which are going on at present. So between 4 to 6, they will definitely join and will boost our morale by their encouraging words. So first of all, let me tell you that I always keep saying that Dr. Seema Mittal always gives a topic, and the bonus of giving a talk in this webinar is Dr. Seema Mittal says, Dr. Bela, take your own time, but we want to learn the subject in depth. So that's the beauty of this webinar, and therefore I enjoy sharing whatever on the topic. I mean, the Dopplers in obstetrics is what we are going to discuss today. And when I asked her, what do you want in that? The most important part was interpretation of Dopplers and how we can practically use them in day-to-day practice. So in clinical utility of obstetric Doppler, we know we have Dopplers in fetal growth restriction and in fetal anemia. These are two very, very important aspects where we have to use Dopplers. Of course, we have Dopplers in twins, special situation, fetal echo, which even at the first trimester, we do fetal echo for cardiac, fetal heart. But I'm not going to go into details of that. I'll just touch upon the role of Dopplers in fetal growth restriction and anemia. Now, let's start with absolute basics of Doppler. So, well, friends, we must know that there is a systolic velocity known as S, and there is diastolic velocity in any waveform of a vessel flow, right? Which is known as S and D. And then there are some indices like S by D, PI, and RI. Now, if you look at the report, still many a times we see this kind of reports, all the vessels, umbilical, middle cerebral ductus, uterine, and the PIs, RIs, S by D ratios, everything is there. Can you make out anything from this report? Can you interpret this? I'm sure the answer is no. So then, how do we kind of interpret and help patients with the help of Dopplers is what we are going to discuss in this, whatever, 30-40 minutes. Now, out of all these values, we must remember that it is only and only pulsatility index or PI, which is S minus D by mean, which is important. And why so? Because PI takes average value of all the velocities rather than just two values in RI. And it does not approach infinity when the diastolic flow is absent. Say, if you see in the S by D ratio, if the diastolic flow, sometimes in the umbilical vessel, you will find in fetal growth restriction that the diastolic flow is absent. In that case, S by D will become infinite, which does not help in the patient management, which never happens with PI, right? So PI is the index that you have to remember about, and do not look at any other values when you look at the report. Now, each vessel that when we use in the Doppler, each vessel gives us some information, whether it's uterine artery, it's umbilical artery, it's middle cerebral artery, or ductus venosus, and we must try and interpret that particular vessel as to what information it provides. So there are uteroplacent Dopplers, that is uterine artery and umbilical artery. Now, uterine artery obviously is entering into the placenta from the maternal side. So it will tell us about the resistance in placenta on maternal side. Whereas umbilical artery is entering in the placenta from fetal side. So it will tell us how much is the resistance in placenta from fetal side. There are fetal Dopplers like middle cerebral artery in the brain, which will tell us how hypoxic or anemic the fetus is. And then we also have ductus venosus, which tells us how good the heart is. So we are going to learn about each vessel and then how we can make use of those vessels in management of fetal growth restriction and fetal anemia. Now, as far as uterine artery is concerned, well, we have learned about it, then we unlearned, and again we are relearning. Previously, we thought that uterine artery is only useful for prediction at 11 to 14 weeks scan. But now we know that any gestational age, it can add insight into the cause of fetal growth restriction and also helps predict perinatal outcome, right? How? We are going to see that. Now, we know there are two waves of trophoblastic invasion into the spiral arteries, which is a branch of uterine artery. The first into the decidual segment at 8 to 10 weeks, and the second wave into the myometrial segment at 16 to 18 weeks, which is of paramount importance, right? Because that is the time when there is loss of the normal muscular elastic structure of the arterial wall, and it is replaced by fibrinode material, which makes the vessel into a low resistance system. So a high resistant artery is converted into a low resistance system through which the flow to the fetus can increase. This is a natural mechanism to improve the blood flow to the developing fetus. Now, so this is how the normal artery will become towards the end of third trimester. And when you look at the uterine artery Doppler, this is the kind of Doppler waveform that you get. I'm not going to go into the technicalities of how to do it today. I'm going to concentrate on how to interpret and make use of it. So this is the typical waveform of uterine artery. Now, as I said, as the pregnancy progresses, the trophoblastic invasion increases, and therefore the resistance in this uterine artery normally reduces. So at 11 to 13 weeks, you will find that the diastolic flow is low, the PI is high. In the second trimester, the diastolic flow improves if you compare, so the PI falls. And in the third trimester, the diastolic flow is very, very good, and therefore the PI is further going to drop. This is how it should happen in a normal pregnancy. But what happens if there is defective second phase of trophoblastic invasion, then the artery will not become low resistance system. It will remain the same high resistant artery. And that is the thing which creates problem. And these are the patients who are going to be at high risk for developing preeclampsia in the second or third trimester, or fetal growth restriction in the second half of pregnancy. Now, this is the example at 11 to 13 weeks on nuchal scan. You can see the diastolic flow is very, very low and the PI is very, very high, more than 95th centile. So when we take a mean PI, when we do a uterine artery PI, we always take the mean of both the uterine artery. And then if that mean is more than 95th centile, then that tells us that this is the patient which is at high risk for preeclampsia. Now, or a fetal growth restriction. Now, how do I come to know, I mean, whether how useful this uterine artery PI? Then this is the slide which is very, very important, because when we calculate the risk for developing preeclampsia or fetal growth restriction, we take into account the maternal demographic factors, the mean arterial pressure, and uterine artery PI, right? So when we just have these two factors, that is the history and mean arterial pressure, the sensitivity of prediction of early preeclampsia is just 51%. But look at this. As soon as you add this parameter of uterine artery PI, the sensitivity improves to 75%, which is very, very good. When you add, I know that usually with nuchal scan, I'm sure almost everywhere we are doing nuchal scan with double marker. So we have PAPE in hand. So when you add PAPE to it, the sensitivity of prediction of early preeclampsia improves to 80%. If at all you have PLGF, the sensitivity further improves to 90% because it's a very sensitive marker. But we know it's a costly one, may not be available in rural area. But then what I always feel that we should do at least what is possible. And I'm sure that at least the history part, that is maternal demographic factors, the mean arterial pressure and the uterine artery PI is the least that we have, and therefore at least 75% sensitivity we can predict preeclampsia, and then we can offer low dose aspirin in the dose of 150 milligram, starting right at nuchal scan, continue till 36 weeks, and we can prevent almost 90 to 95% of severe form of preeclampsia. That's the beauty of this simple parameter, that is uterine artery PI, which adds a lot in management of these patients. Now, we have this calculator for calculating risk for preeclampsia, which is available online to each and every one of us. FMF UK has this online calculator in which you just have to feed in the data, the history part, whether the patient is diabetic, hypertensive, height, weight, all the demographic factors, the mean arterial pressure, and the mean uterine artery PI. And if you have available biochemistry, either PAPE or PLG, if you add everything, click on the calculate risk. And if this risk is more than 1 in 100, then we are supposed to start the low dose aspirin, and we can help prevent preeclampsia. So that was about the uterine artery, which has a very major role. Number one, we saw in prediction prevention of preeclampsia. Now, other artery which is important is umbilical artery. And we know there is a pump, pipe, and receiver. The fetal heart is the pump, and the pipe is the umbilical artery, and the placenta is the receiver of this blood. So what information do you get from umbilical artery? Well, when you insonate or you do Doppler, you will get a systolic wave and you will get a diastolic wave. Systolic wave will tell you how good the fetal heart is or the contractility is, whereas diastolic flow will tell us how less is the resistance in placenta. So that the information about fetal heart as well as placenta is what you are going to get from the umbilical artery. So normally when you do a Doppler of umbilical artery, this is a normal waveform of umbilical artery that you will find. There is usually a good diastolic flow, and the umbilical artery PI is usually on the lower side in a normal pregnancy with lower placental resistance. Now, what happens in early onset fetal growth restriction? Umbilical artery is very good for umbilical in the early onset fetal growth restriction, which develops before 32 weeks of pregnancy. right? Here it is going to help us how to identify fetal growth restriction. It helps to differentiate between small for gestational age and fetal growth, and also helps in monitoring how, and I am going to tell in my next few slides. But the reason here is, in early onset fetal growth restriction, as you can see in this slide, okay, it is going to come little later. In early onset fetal growth restriction that develops before 32 weeks of pregnancy, you will find that the resistance in placenta is very, very high. There is a placental insufficiency, which is more than 30% or more than 1/3 of the placenta is affected. And that's the reason the changes you will find in the umbilical artery. Whereas what happens in late onset fetal growth restriction, that the placenta damage is not much. The placental damage is less than 30% in late onset fetal growth restriction, and therefore you will not find much change in umbilical artery waveform. So that's the limitation of umbilical artery. But let's look at what happens when there is actual placental insufficiency. Well, with increasing resistance in placenta, you will find that the umbilical artery PI gradually increases, and that gives us information about how bad the placenta is. And even if you just have a look at the umbilical artery waveform, it gives us lots of information. Now, again, this slide is very, very important, because even if I look at this image of umbilical artery waveform, well, when I look at the PI is high. This value for this gestational week will fall more than 95th centile. So when the PI is more than 95th centile, but the diastolic flow is still there, that tells me that almost 30% of placenta is damaged. But if the diastolic flow is absent, as you can see in the second image, that tells you that almost 50% of placenta is not functioning. But again, if there is a reversal of flow in the diastole, as you can see in this image, that tells you that almost 70% of placenta is not functioning. So look at this. When you look at the report, you are not just going to look at the conclusion or the value of PI. You also have to look at the waveform of umbilical artery, and this itself tells you how much of the placenta is affected, whether it's 30%, 50%, 70%. And that helps you in management of early onset fetal growth restriction. So this has to be kept in mind when you look at the report. Please have a look at the images as well. So that was about umbilical artery. What about middle cerebral artery? Well, middle cerebral artery in the fetus is very, very sono-friendly, easy to do, reliable, and very less inter-observer variability. But so usually when we take BPD in the same axial section, we go down at the base of the skull, and we are going to find in the circle of Willis the middle cerebral artery. Now, when you try to do this Doppler of middle cerebral artery, normally the PI of middle cerebral artery is high, the diastolic flow is low. So if you compare with our umbilical artery waveform, the PI in the middle cerebral artery is always on the higher side as compared to umbilical artery. And why is this important? Because we are going to talk about the utility of middle cerebral artery. Well, whenever there is hypoxia, fetal hypoxia, that is in fetal growth restriction, what will happen is the baby is going to try and reflexly try and improve the blood flow to the brain by the reflex in the carotid chemoreceptors, and then the brain sparing effect is there by increasing the diastolic flow. Now, what happens when there is increase in the diastolic flow? Obviously, the middle cerebral artery PI is going to fall, which should usually remain high. So when you see a very good diastolic flow in the middle cerebral artery, as you can see in this image, that is telling us that baby is trying to compensate for the hypoxia, and therefore the diastolic flow has improved. Now, when it comes to middle cerebral artery, rather than just taking the value of MCAPI, what is important is the ratio of MCAPI to umbilical artery PI, which is known as cerebroplacental ratio. And I'm sure you all must have heard of CPR or cerebroplacental ratio. A lot is being talked about CPR these days. Now, why is this ratio important? Because the sensitivity of CPR or this ratio of MCAPI upon umbilical artery PI is much higher than the sensitivity of only MCAPI to detect fetal hypoxia. So when this cerebroplacental ratio is low or less than 5th centile, it tells us that there is hypoxia and there is forced centralization and there is brain sparing effect. CPR less than 5th centile tells us that there is a brain sparing effect. Now, what is the importance of CPR less than 5th centile? If in the report you find that the CPR is less than 5th centile, how should we interpret it? Well, its role is different again in early onset fetal growth restriction and late onset fetal growth restriction. Why so? Early onset fetal growth restriction is something which develops before 32 weeks, where the placental resistance is high. So when you find that your CPR is less than 5th centile before 32 weeks of pregnancy in early onset fetal growth restriction, it tells us that fetus is hypoxic, but it is still trying to auto-regulate by improving the blood flow to the heart, and therefore the fetus can still cope. It is not a trigger for delivery in early onset fetal growth restriction. Whereas what happens in late onset fetal growth restriction? As I said, the reason is different, the mechanism is different in late onset fetal growth restriction, and these are term fetuses who cannot tolerate even the minimum or the mild hypoxia, and therefore if you find that the CPR is less than 5th centile in late onset fetal growth restriction, which develops after 32 weeks of gestation, then it raises a red flag, and that fetus has to be closely monitored with the help of daily fetal movement count, CTG and NSG, because these are the fetuses who are at very high risk of developing sudden stillbirth. I'm coming to the individual management of fetal growth restriction and anemia as well. At present, we are talking about each vessel separately first. Next, we are moving on to ductus venosus. Now, ductus venosus is a vessel which connects the umbilical vein with the heart or the right atrium, and therefore it is going to tell us about the pressures in the right atrium. Now, it is usually triphasic. You can see one systolic, diastolic wave, and there is a tiny A wave here. But this tiny A wave is what is extremely important, and we always have a look at this tiny A wave. So, whenever there is either absent or reversal of this tiny A wave, it tells us that the pressure in the right atrium is high and the fetus in the heart is failing, and this is a very bad omen. It predicts acidosis in fetal growth restriction. It tells that the reversal of A wave tells us there is a very high suspicion of acidosis and fetus can die within hours. So if at all you see a reversal of A wave in ductus venosus, you cannot wait, but you have to deliver the baby at the earliest, and that we'll discuss in the management of fetal growth restriction. So as I said, I'm going to discuss about the clinical utility of all these vessels Dopplers in fetal growth restriction and fetal anemia. Now, what happens in fetal growth restriction? We know, well, when it is less than 10 centile, it is small for gestation age. Normal is between 10 to 98 centile. So when it is the fetus, the growth is falling less than 10 centile, it is a small for gestational age. So my next job is to find out whether it is just constitutionally small fetus or pathologically small fetus. That means whether it's a SGA or fetal growth restriction. Here my Doppler comes to help me, because if the Doppler is abnormal, it tells us that there is placental insufficiency as a cause of this, and this is a fetal growth restriction and not a healthy, normal, constitutionally small fetus. It also helps us to find out the cause of fetal growth restriction, because if the Dopplers are abnormal, we know it is placental insufficiency and not some chromosomal or structure anomaly which is giving rise to fetal growth restriction. It has an important role in management and timing of delivery, and also in prediction of and prevention of preeclampsia and fetal growth restriction that we know with the help of our uterine artery PI. So this we discussed that if the Dopplers are abnormal, it tells us that it is not just small for gestational age, but pathologically a fetal growth restriction. Now, why is it important to differentiate between small for gestation? Because in general, small for gestation has good outcome, needs little less follow-up when you are monitoring these fetuses as compared to abnormal Doppler with fetal growth restriction, because management is a challenge. It's an early onset fetal growth restriction and we have to monitor them very, very closely. How? We come to know through my 1 or 2 slides. So as I have been repeatedly mentioning about early versus late onset fetal growth restriction, it is the early onset fetal growth restriction which develops before 32 weeks, which is the severe form of fetal growth restriction. The fetus may be very, very small. You'll find all the abnormal Doppler of umbilical, MCA, ductus venosus in this form of fetal growth restriction. It's a severe form. The late onset fetal growth restriction is not severe because placenta is less than 30% affected, but CPR is what is extremely important, and you'll find this brain sparing, and that fetus has to be monitored through the kick count and the DFMC and the NST, right? Now, as I said, Dopplers have very, very important role in diagnosing fetal growth restriction, because we know International Delphi Consensus has given us this definition, which we all have been using internationally to diagnose and manage fetal growth restriction, and that uses all Doppler parameters. So what is early onset fetal growth restriction? Well, you need your Doppler parameters, because either the abdominal circumference or EFW less than third centile, or your umbilical artery has absent and diastolic flow without any abnormality, also it is called the fetal growth restriction. But if any 2 of these are present, that is ACFW less than 10 centile with either uterine artery PI more than 95th centile or umbilical artery PI more than 95th centile, then also it is called early onset fetal growth restriction. So if you have not done your Dopplers, how are you going to diagnose your fetal growth restriction? Similarly, in late fetal growth restriction, 2 of the 3 criteria is what is needed to diagnose your late onset fetal growth restriction. Either the AC or EFW less than 10 centile, or ACFW crossing more than 2 quartiles. What is 1 quartile? It is 25 centile. So 2 quartiles is 50 centile. So if the growth has fallen by 50 quartiles, that means say at 20 weeks, the growth of the fetus was at 75th centile. And at 32 weeks, when I am doing, the growth is at 25th centile. That means it has fallen by 50 centiles. That is 2 quartiles. That also tells us that this is fetal growth restriction. Or when the CPR is less than 5th centile and your umbilical artery PI more than 95th centile, any 2 of out of these 3 are present, then we diagnose as fetal growth restriction. So again, we need our Doppler parameters to diagnose this. So all must know these to diagnose, otherwise we'll not be able to manage them. Well, now once we have put the diagnosis of fetal growth restriction, again this slide is very, very important, and I wish all of you must have a printout of this chart of Barcelona staging in your OPD, because this is the one which is going to help you manage all the fetuses with fetal growth restriction. As soon as you get your Doppler report, or if you are doing on your own, look at this chart and try and manage accordingly. If you send it to sonologist, look at the values and then see whether it is stage 1, 2, 3, or 4, because that is going to decide when to deliver this baby, right? So stage 1 is one in which there is mild placental insufficiency. EFW is in 3rd centile. CPR less than 5th centile, umbilical artery PI more than 95th centile, or MCA more than 95th, or uterine artery. Any of this is known as stage 1. But see, what is important here when you are looking at all these criteria, they are mainly based on umbilical artery and ductus venosus. Umbilical artery PI more than 95th centile, but you still see some good diastolic flow. That means it is stage 1. It is not yet end diastolic flow in the umbilical artery. That is stage 1, in which you can weekly monitor with Doppler, pull it till 37 weeks, and you may even induce and deliver then at 37. But beyond 37 weeks, you should not wait, because that can be stillbirth. Stage 2 is one when in the umbilical artery waveform, there is absent end diastolic. There is no diastolic flow in the umbilical artery. Only systolic flow is there. That is stage 2, where there is severe placental insufficiency. As I said, 50% of placenta is not functioning. So you have to monitor not just bi-weekly. I would prefer to do every alternate day Dopplers, because I have to check from when that end diastolic flow becomes reversal, right? So likewise, if it remains same till 34 weeks, by monitoring, you can pull on till 34 weeks and then deliver by C-section, because these are the fetuses which are at very high risk of developing acidosis if you induce a labor. Stage 3 is when in the same umbilical artery waveform, you find that not just absent, but there is reversal of end diastolic flow. That tells us that there is not just hypoxia, but there is fetal acidosis, low suspicion of fetal acidosis. And there almost you have to admit the patient, and I would do daily or morning, evening Dopplers to see if my DV is becoming abnormal, right? And similarly, this usually, as I said, all these findings in umbilical artery and DV you will find in early onset fetal growth restriction, maybe at 26, 28 weeks, 30 weeks. So if you can pull this pregnancy by repeating Dopplers and admitting till even 30 weeks, that's fine. Then just do section and deliver the baby, because baby is at very, very high risk of stillbirth. And the stage 4, as I said, when there is reversal of A wave in ductus venosus, that's the time we know we don't even wait for 12 hours. We deliver the baby as early as possible, because otherwise there'll be fetal demise. So even if it is just 26 weeks, you have to do section, counsel the patient, because otherwise there'll be stillbirth. Okay. So unless and until we make use of this chart, we will not be able to pull the pregnancy to the maximum. We know that in fetal growth restriction, we have to weigh the balance between prematurity and stillbirth. Neither the baby should be delivered too prematurely, nor there should be stillbirth in the uterus. So this is the chart that's going to tell you how much you can pull, whether to monitor weekly, bi-weekly, every second day, daily, right? So looking at the parameters, we'll be able to manage the fetal growth restriction. Initially, I had shown you this Doppler report, which shows all values of all the vessels, PI of all vessels, RI of all vessels, S by 2, and doesn't give any conclusion. This kind of reports do not help us at all. So how should we have a report of Doppler? A proper Doppler report is one which just gives us important values of uterine artery PI, umbilical artery PI, DV PI, and cerebroplacental ratio with centile. Ask for all these values from your sonologist with centile, because then you will be able to find out as to what stage of fetal growth restriction it is. As I said, by looking at the umbilical artery PI, whether it's just high PI or absent end diastolic flow or reversal, you'll be able to stage, and you'll be able to monitor the patient. So it will tell us how frequently the patient should be followed up and how long we can prolong the pregnancy. So that is what is expected out of a Doppler report. Otherwise, that Doppler report is of no value, and the patient is just wasting the money on the Doppler report, right? This much information has to be there in the Doppler report. So typically, what we mention in the Doppler report is gestational age, whether it is agreed based on LMP or nuchal scan. that is the weeks of gestation, then the growth at whatever centile, this here it is at 4th centile. Then there are Doppler findings, umbilical artery PI, cerebroplacental ratio, DVPI, uterine artery PI. We can see the umbilical artery and the uterine artery both PI are more than 95th centile. The growth is less than 10th centile. So what is this? This is growth at 4th centile with uterine and umbilical artery PI more than 95th centile. So I know for sure this is a stage 1 fetal growth restriction. And then because it is high uterine artery PI, I know the cause also, that is placental insufficiency. And then I know because it is stage 1, I'll have to call the patient back after a week for Doppler. So absolute clarity based on this report. The patient also knows she has to come after a week. And of course, she has to keep a kick count and come to you whenever she feels any problem, right? So this is how you'll be able to save almost all your growth restricted babies if you make good use of Dopplers. Now, what about the role of Doppler in fetal anemia? We all know that is Rh negative mother. Now, gone are the days when we talked about Lily's chart and amniocentesis and try and find out bilirubin. No. We have this beautiful tool of ultrasound, and that is MCA-PSV, which is a non-invasive test, which tells us clearly how anemic the fetus is. And it's very simple to remember. In anemia, the middle cerebral artery peak systolic value increases, and when it is more than 1.5 MOM, it tells us that baby is anemic. When it is less than 1 MOM, baby is polycythemic. Now, why? We must try and find out as to why the PSV should increase in anemia. Well, in anemia, what is the physiological response? Whenever there is anemia, the heart will try and increase the stroke volume. So it will increase the cardiac output. There will be hyperdynamic circulation, which increase the peak systolic velocity. Not only that, there is decreased blood viscosity in anemia and therefore increase in blood flow, which ultimately increases the peak systolic velocity. So till now, we have only talked about PI of all values for fetal growth restriction. Only MCA-PSV, that is peak systolic velocity, is only one parameter which is important, and that too in fetal anemia. So in fetal anemia, we don't look at the PI. We look at the mean, the MCA peak systolic velocity. See, well, there are some technical points because angle of insonation has to be less than 15 degrees. Otherwise, your peak systolic velocity is going to go wrong. The ratios are not affected by the angle of insonation, but the peak systolic velocity is affected. So the sonologies, if you are doing, you have to be very, very careful. You have to train yourself well to do MCA-PSV so that the angle of insonation is less than 15. Otherwise, your MCA-PSV will be absolutely wrong. Right? It has to be between 0 to 15, preferably close to 0. Then you'll get perfect PSV, which will tell us whether the baby is anemic or not. And the fetus has to be still. It should neither be breathing nor be moving. So these are few important points while doing MCA-PSV. Now, when the MCA-PSV is more than 1.5 MOM, it tells us that baby is severely anemic. The hematocrit would be very, very less than 30%. And that's the time you need to do intrauterine transfusion. So if you are monitoring this fetuses of ICT positive Rh negative mother, then immediately the patient has to be referred to higher center where intrauterine transfusion can be done. Or if you are interpreting based on the sonologist report also, the patient immediate referral for intrauterine transfusion is what is important. So that's the importance of this non-invasive method of knowing anemia. Now, you may have a question, madam, how do I know whether the MCA-PSV is, I just know the value of MCA-PSV. How do I know the MOM, whether it's more than 1.5 MOM or not? So again, we have beautiful online calculators and online sites available. We have perinatology.com. We have FMF UK calculators in which you just have to put in two values, that is gestational week at that particular ultrasound when it was done, and the MCA-PSV value. And it will tell you what the MOM for that particular week of gestation. And if it is more than 1.5 MOM, it tells you that. So every obstetrician can make out whether it's more than 1.5 MOM. Not only that, there are some charts available, and that gives you rough idea as to whether suppose at 32 weeks I'm looking at, then it will tell you that if it is more than 95th centile, more than this, then it is more than 95th centile, because this is 1.5 MOM. And roughly, if you want to see at any gestational age, suppose at 30 weeks or 31 weeks, if roughly I want to calculate, if it is double the weeks of gestation, the MCA-PSV. So at 31 weeks, if it is more than 62, see here, then I know that it is more than 1.5 mm, right? That's a rough estimate of calculating MCA-PSV, whether it is more than 1.5 mm and whether the baby is really severely anemic or not. So that was about role of MCA-PSV in fetal anemia. Now, what about role? We have discussed about do's of Dopplers in fetal growth restriction and anemia. We must also know about some don'ts. What is the role of Doppler in gestational diabetes mellitus? Well, in just isolated gestational diabetes mellitus, where there is no placental insufficiency, there is no role of Dopplers. Yes. Why? Because Dopplers just tells about fetal hypoxia and not hyperglycemia. It doesn't tell about the sugars in either the fetus or the hyperglycemia or the acidosis which is caused by hyperglycemia. No. So even if the baby is going to die in 1 hour, the Dopplers will be absolutely fine. So please don't get relieved by looking at the very good Dopplers and you are fine. Don't tell the patient, right? Yes, it tells you about placental insufficiency, but not about the sugars. So in GDM, Dopplers have no role. You have to have a very good, strict glycemic control to prevent stillbirths, right? So we know how important this tool of Dopplers is to us. I feel that every obstetrician is like this goddess with multiple, weapons and tools. And with us, we know that ultrasound is a very, very, very strong tool. And in that, Dopplers in particular, we know right from the first trimester to second and third trimester has a very, very important and pivotal role to manage all our fetal growth restricted babies, to prevent preeclampsia and fetal growth restriction, and also to manage anemia and many, many other roles, as I said, in twins and fetal echo and all, which I have not discussed in this talk, maybe some other time. So that was about the role of Dopplers. And I'm coming to the end, but before that, I would just like to invite you all to this physical 2 days conference of Imaging Science Committee of FOGSI with Navi Mumbai OG Society on 9th and 10th March. That is coming next to next weekend. We are having a beautiful 2 days conference where we have made fetal medicine simplified for all the obstetricians. It is for all the practicing obstetricians, where we have national faculties coming from Kochi and Pune, and we have chosen the topics such that you get overall from basics of ultrasound in pregnancy to the advanced role of ultrasound. So I welcome you all to Navi Mumbai to this unique conference of Imaging Science Committee, a physical conference. So with that, I'll conclude my talk. As Reshmi also told, I always wish that every obstetrician learns to do ultrasound on their own, because if I can learn, I think every obstetrician can refine that skill and help the patient. With that, I conclude my talk. Thank you so much for patient hearing. Thank you.
Thank you so much, Dr. Bela. That was outstanding. You know, you gagar mein sagar is what we say, na? Chote mein aapne sab bata diya. So, very, very nice.
Thank you.
And Dopplers, I totally second what you say, that if I can learn Dopplers, anybody can learn it. And we gynecologists should learn to do our own Dopplers and also to actually interpret them. Delphi and this and doing them correctly, we learn so many great skills. What's so great about this? So we should actually learn. And that was really very good. Thank you for having me here. Thanks a lot.
Thank you, Dr. Bela. This was super brilliant inputs we got. And I think you are the treasure which is to be shared with every FOGSian. I enjoy each and every word of what you say. And it was a pleasure having Dr. Reshmi and Dr. Asha Jain with us. Dr. Asha Jain, ma'am, we really welcome you on this platform, and we are very, very happy and thankful to Dr. Bela that she made you join this platform. And Dr. Asha Jain, I think everybody can read got such a detailed academic achievements. She's a certificate and instructor in FCC OB course, and she has got Special Academy of Gynae Ultrasound Fetal Medicine and Obstetric USG, and she's FMF UK certified. She's the director of SMS SA Hospital, Raipur. Ma'am, it was really pleasure to have you with us. And Dr. Reshmi Banerjee, we have known little bit about you, that you are Dr. Bela's. They're from the same alma mater, you said, and we have known you for the first time.
Dr.
She's
Seema,
my-
let me tell you that Dr. Reshmi is very, very active academically, and in IMS, she has played a very, very important role in all the conference all over India. So she does a lot of academic activities, being based at Baroda also. She does a lot of, she's very, very active member of IMS. And in FOGSI, my committee also, she's member of my imaging science committee, and she has done visited so many centers to recognize them for ultrasound
Thank
approved.
you, Bela.
pleasure connecting to you, Dr. Reshmi. Tell us about Dr. Asha also. Dr. Bela, you know them. You know
Yes, Dr. Asha, I have known again. First time we met Dr. Asha was when I visited her center to approve for the FOGSI recognized center at Raipur, and it was installation ceremony. She is again very, very active, not just with the FOGSI, but with SFM also. And she has been doing lot of webinars with Society of Fetal Medicine, and constantly, I think every week, a webinar is being done on some of the important topics related to fetal medicine and ultrasound, right, Dr. Asha? So,
Yes,
Thank
ma'am.
you.
Thank
Thank
you
you,
for
Dr.
those
Asha.
kind words.
always pleasure to have Dr. Asha Jain and Dr. Reshmi Banerjee with
It's
us.
Thank
happy
you so
learning and
much.
Thank you, Bela.
it's
Thank
happy
you,
learning
Bela,
and
for all
happy
the
knowing.
I can see Dr. Gitendra Sharma also. Dr. Gitendra
Yes.
Sharma, welcome.
We are
We
the,
know
we
him,
are the-
an ace, a medical legal expert in India, and the immediate past vice president FOGSI, and I had the pleasure to have sir as my VP in charge last year, and I have done a lot of activities under him. So thank you so much for joining, Dr. Gitendra Sharma, and we are all waiting to hear you.
Yeah, he's the best legal advisor, and whenever you are in distress, just give a call, and he's just a call
Yes.
away. Thank you so much, sir. Words cannot tell me. I invite the chairperson, Dr. Sunil Takia, to introduce our speaker, Dr. Gitendra Sharma. Practicing gynecologist and obstetrician in Ahmedabad for last 28 years, author of books Law in OBGY, Consents in OBGY, Laws a Doctor Must Know. And so please tell us all about ART, law and act, and how do we have to follow so that we don't need to call you ever. Over to you, sir.
At the outset, Madam, I would like to thank FOGSI Imaging Science Committee Chairperson Dr. Bela Bhatt for inviting me for this webinar. I once pay my regards to Rewari Obstetric Gynecological Society, Dr. Seema Mittal. I give my thanks to Haryana IFS for giving me this opportunity to be part of this webinar. We all know that ART is a hot topic nowadays, and whoever is practicing ART is always in so much dilemma that what to do and what not to do, because every information provided by different people from different fora are different. So hope I will be able to provide you exactly what I mean to say. So we are going to discuss ART Act and Rules, what is new. So let us understand what is new. So we all know that before this ART Act, there were multiple national guidelines for accreditation, supervision, and regulation of ART clinics in India. There was ART regulation, is ICMR guideline 2005, then ART regulation bill and rules bill in 2010 came. Then ART regulation bill 2014 and 2017 came later on. So everybody was in dilemma that which was applicable, and only God could give answer that what is applicable.
Thank you, sir.
Waiting for a law since last 44 years. since birth of first child, Louis Brown, through the technology of in vitro fertilization by Robert G. Brown in 1978. And we all know that in the same year, after a few days, around 60 days, birth of first IVF baby Durga on October 3, 1978 by Subhash Mukhopadhyay in Kolkata. So we were waiting since then for a law to regulate ART. And ART Act came in 2021 and it was implemented in 2022. See, the ART Regulation Act 2021 got assent of President on 18th December 2021 and it was published in Gazette on 20th December 2021. But with separate Gazette, the date came for this act to be enforced, that came on 25th January 2022. So ART Act is implemented in India from the date 25th January 2022. And ART rules were gazetted and implemented from 7th June 2022. So they came into force from 7th June and they are also published directly in Gazette on 7th June. Only one good thing about this act I can say is that at least something has come out to regulate this unregulated sector. So we all know that before this law came, nothing was regulated. Nobody was following the ICMR guidelines strictly, and everybody was practicing in their own way. And there were unethical avenues which were open for doing practice. ART Act 2022, I always say that these are blunder. It seems that Act is enacted by people who have no knowledge of medical science, and they even did not bother to take advice of a medical person in a proper manner. Act is enacted in such a way that every ART practitioner will practice in dilemma and on the mercy of appropriate authority. Because as there is no clarity that what should be how it should be interpreted, every appropriate authority is going to interpret in their own way, and this will open the avenues of corruption for sure. Dear friends, we are practicing like this in our OPD. So every patient is a potential litigant, and we as a doctor in our OPD has to save ourselves to complete our whole day in OPD. So we are always confused. See, the ART Act is a confusing act, and nobody knows that where to go, how to go, and how to practice now. See, the point number one we are going to discuss today is regarding the ART bank. See, in ART Act, Section 21B, it is mentioned that ART bank has three functions. First, they will collect the gamete, they will store the gamete, and they will supply the gamete. But in the same act, in Section 27, something else is mentioned. And in Section 27, it is mentioned that the ART bank will only screen the gamete donors. They will store the sperms only, and they will supply the oocyte donor to the ART clinic. So basically, they will collect, they will store, and they will supply the sperm. But in case of oocyte donor, they will only screen the oocyte donor and they will supply the oocyte donor to the commissioning couple or to the ART clinic. Now, there is vast difference in these two statements. First is Section 21B, that is the section of definition, and 27 section is a section which is a part of ART Act itself. At multiple places, multiple different things are mentioned in the same act. Now, what to follow? So, dear friends, there are multiple questions which comes to our mind, that For registering ART bank, the facilities which are required, infrastructures which are required, that does not contain the things for oocyte storage. So that means, or ovum pickup. So that means ART bank cannot do ovum pickup and they cannot store oocyte also. So how can they supply oocyte? Previously, many multiple ART banks were there which were storing the oocytes and they were supplying oocytes on demand. But now it is not allowed. So we should be clear in our mind that whatever is mentioned in section 2(1)(b), but the role of ART bank is now limited to only screen the oocyte donor and supply of oocyte donor to the ART clinic for ovum pickup. And second, they will collect, they will screen, they will collect, and they will supply the sperms of the sperm donor to the ART clinic. So this should be clear in our mind. Second question which comes to in our mind, that the definition of infertility is again given in ART Act. And it is said that if a couple remains infertile after 1 year of unprotected coitus, then it is said that they are infertile. So in India, the age of marriage for a female is 18 years. We all know. That means if she continuously doing sex without protection, and if she does not become pregnant, then she is stamped, she can be stamped as an infertile. Now, at 19 years, she is stamped as infertile, but as per ART Act, the minimum age to start the ART treatment is 21 years. So you can treat only patient, only lady who has age in between 21 to 50 and male whose age is 21 to 55. So dear friends, at the age of 19 years, the stamped infertility diagnosis is there. But even though the diagnosis of infertility is there, but you cannot treat the patient with any ART procedure. Let us understand what is ART procedure. So ART procedure, if you go through the definition of ART, it defines that you have to take out gametes from the body. You have to do something on that gametes, either wash it or make an embryo outside the body, and then transfer the gametes or embryo inside the womb. So then it becomes an ART procedure. So we should keep in our mind that only stimulation is not ART. ART means when you transfer the gametes. So IUI is an ART procedure. Or if you transfer the gametes, so making embryo is not an ART procedure, but transferring embryo in the uterus, then it becomes an ART. So we have to be clear in our mind that although oocyte preservation, fertility preservation is the part and parcel of ART Act, so it is also to be regulated by ART Act, but oocyte preservation is not an ART procedure. So as it is not, and because here we are preserving only the oocyte, we are not making embryo, we are not transferring anything in the body. So it is only a preservation of oocyte, which is not ART procedure, for which no formalities are to be done and only signature of female is required to preserve the oocytes. Regarding registration, we all know that there is chaos everywhere. In UP, in Bihar, in many parts of Gujarat, till date, no registration is being given to many centers who had applied even before July 2022. They are waiting for registration for last 1.5 or even more years. So it is surprising. In the Act, it is mentioned that registration should be, the doctor should apply to the authority, National Commission, through appropriate authority. But we are applying directly online to commission. That is one issue. Second, it is said that once application is done, it is the duty of appropriate authority to give registration within 60 days. Now, if they do not give the registration, then they have to give answer. But here, even after application, the registrations are not given for last 1.5 and even more years. Who is answerable? For last many months, even the site of national board is also been corrupted and it is not opening. So if somebody wants to apply afresh for new center for registration, what is the procedure? Nobody knows. So this is surprising. So it is a chaos, I can say. On one side, it is said that appropriate authority after inspection and after satisfying himself will issue the registration within 30 days. And on the other side, it is mentioned that appropriate authority cannot issue certificate unless state board visit the center and satisfy themselves that center satisfies all the requirements of as per the act. So what is the exact procedure? Nobody knows. See, in Pune and in many centers at Hyderabad, Telangana, the registrations were issued by the appropriate authority. But later on, state board objected that we had not done any inspection in a particular center. So how can you issue the certificate? And even after giving those certificate, appropriate authority was forced to withdraw those certificates from those centers. Until date, those centers are not been given registration. Now, without registration, whether you can work or not, nobody can answer. And if you have not applied before 22nd July, so if you have applied after 22nd July, after implementation of the act and rules, means 6 months after the implementation of the act, if you have not applied, and after that, if you have applied and if you have not received the registration, you cannot practice as per law. So you can be given notice. Many doctors are being given notice in Pune for practicing without registration, only on application, where application was done after in August or September 2022. That was after the last date, 25th July of 2022. So dear friends, it is a chaos, I can say. And the answer is that if you have applied for the registration after 22nd July and you have not received registration, as such, you cannot start practice, but you can definitely proceed to High Court for getting the relief in this regard, and then you can start the practice. In ART Act, it is said that every ART clinic should have a grievance redressal cell in their hospital or in their clinic. Now, who will be the member? How many people will be the member? Whether there will be independent member or not, nothing is clear. What will be the role of grievance redressal cell? How they will function? How they will receive the complaint, and how they will handle the complaint. So nothing is clear in the act, and everybody is in dilemma that what should be done and how grievance redressal cell should be formed. Whether it should be a 3-member or 5-member or 7-member or 9-member cell, nobody knows. See, in most of the acts where these kind of cells are to be done, which are mandatory. See, according to, we all know that there is some internal conduct committee in the hospital, which is now mandatory, where female are working. Previously, it was known as Vishakha committee or sexual harassment committee. So in that committee, it was clearly mentioned that who should be the member, how many members should be there, whether they should be independent member from the hospital or whether they are from the hospital, how they will function, what will be their rights and what will be their duties, how much will be their rights, what punishment they can give to the culprit. So everything is mentioned in that. But in this grievance redressal cell, only one line is mentioned, that every ART clinic should have grievance redressal cell. How it will work, what he will work, nothing is clear. Previously, there were Form M, Form M1 and M2, in which we were providing information of sperm donor, oocyte donor, and surrogate to the commissioning couple. Now, in this act, we all know in ART Act, these forms are being removed. So there is no form M, M1 or M2. Now, how ART bank will convey the information of donor to the commissioning couple is not known to anybody. Even in the act, there is no word used like anonymity. So whether we should maintain anonymity of donor or not. Suppose if donor wants to maintain anonymity, then we have to maintain. We cannot reveal the name if donor does not want. So the question can be answered in the way that in act anonymity is not mandatory, but it is optional for donor and commissioning couple to maintain the confidentiality of the information of the donor from the third party. So, insurance coverage. Again, it is mentioned in the act that if you select a donor, then it is mandatory that commissioning couple will take insurance coverage in the name of oocyte donor for 1 year, and which should cover all the complication, including death of the donor, and that should be of reasonable amount. So one flaw I can say, that amount is nowhere mentioned. So nobody knows that whether you should take insurance of 1 lakh or 2 lakh or 3 lakh. Second, there is insurance available which covers all oocyte donor complication as well as death. So whether you should take health insurance as well as life insurance both together or separately, there is no answer. It should be IRDA recognized. The company who is dealing should be IRDA recognized. Now, IRDA recognized companies have not come out with the clear mandate that they will cover the complication of oocyte donor from the very first day, because there is always a 60 or 90 days window period. After that, they will start covering. But a few companies have now come out. So we have to see first before taking insurance, that whether they are covering the complications of oocyte donor, whether they are giving in writing or not, and only then we should take insurance. In one of the webinar, one of the national board member was telling that we should start taking health insurance as well as life insurance in the name of oocyte donor, because no health insurance covers the death of oocyte donor. So again, there are multiple answers of a single common question and nothing is clear, but at least you should take health insurance, and what we feel that it should be at least of 2 lakhs rupees in the name of oocyte donor. Consents. See, we all know that in ART Act, form number 6 to 15, except form number 14, which is a record, but 6 to 15 are the consent. Form 6 is the consent when patient is undergoing ART, and commissioning couple's consent should be taken in Form 6. Form 7 is for IUI husband. Form 8 is for IUI donor. Form 9 is for embryo freezing. Form 10 is for fertility preservation. Form 11, if you do fertility preservation in a minor, then it is a guardian's consent. Form 12 is the oocyte retrieval form. Form 13 is the oocyte donor's consent, and Form 15 is a sperm donor consent. So these are all consent. Surprising to see that there is no consent of embryo transfer and TISA, that is sperm retrieval, in this act at all. So previously we all know that there was Form I, which was used for oocyte retrieval as well as for embryo transfer. But now there is no form at all in this act for embryo transfer. So at the time of embryo transfer, where to take consent, where to write the number of embryos you are transferring in the uterus is not clear. Whether you are doing frozen embryo transfer or fresh embryo transfer, there is no provision of writing this information in any of the consent form. So later on, if any dispute will occur, then you will have to face problems. And that's why we always recommend that even after there is no consent in this act, you should continue taking consent of commissioning couple undergoing embryo transfer in Form I. And you should put the information regarding the number of embryo and regarding the fresh or frozen embryo or the combination of gametes which you are using to make the embryos. So we all know previously in Form I, that was for oocyte retrieval, there was clear-cut information that how you will prepare the embryo, whether you will prepare the embryo with the self-oocyte and self-sperm, or donor oocyte and self-sperm, or donor oocyte and donor sperm, or I can say self-oocyte and donor sperm. So whether you do self-ICSI or OD-ICSI or ED-ICSI or DS-ICSI, it was clear in Form I. But in Form 12, which is given now in new act, that is for oocyte retrieval, in that there is no such information that what gamete you are going to use to make the embryo. So surprisingly, I have seen that in ART Act, whatever these allegations are being put against doctor is in regard to gamete only, that we had given consent for self sperm and self oocyte. Why did you use donor oocyte? Or why did you do ED if we have given permission for OD-ICSI or self-ICSI only? So these are all the disputes normally in regard to gametes, and no consent speaks about it. Although in Form number 9, there is mention that whose sperm and whose oocyte you have used, but that is a consent of freezing, and consent of freezing comes into play only after embryos are formed, not before that. So it is surprising that at the time of making embryo, we do not have any consent in our hand in regard to the selection of gametes, which is agreed by the patient. And we cannot prove it in the court of law by any consent. So that's why we always recommend that you should continue taking Form I for oocyte retrieval also, over and above this Form 12. We have seen that the consent provided in ART Act are not as per the Supreme Court guidelines, which is given by Supreme Court in Samira Kohli versus Dr. Prabha Manchanda's case. See, we all know that all consent should have 6 things. 1, what is the purpose of treatment? 2nd, what is the procedure you are going to do? 3rd, what are the success and failure rates? 4th, what is the alternative? 5th, what are the risks of the procedure? And last but not least, 6th is that if you will not undergo this treatment, what will be the problem? So if you contain these 6 things in the consent, then only it will become a complete consent. All the consents which are being provided in ART Act are incomplete as per the definition given by Supreme Court. And that's why we always recommend that over and above these consents, see, these are the consent which are given in Act, so it is mandatory to follow. So whether they are inadequate or not, we have to follow. But over and above these consents, we should take a few more consents to protect ourselves. So procedure specific consent for embryo transfer, procedure specific consent for ovum pickup, and other procedure specific consent for IUI, etc. should be taken. We should develop a habit to take such consent. It is mentioned in the Act that ART bank should be an independent entity from the ART clinic. It is mentioned in section 27. Now, what is the meaning of independent entity? Previously, before clarification and before this registration form we received, we were always telling everybody that independent entity, it was not clear rather, but we were interpreting it in a way that it should be a separate premises, it should be a separate owner, and there should not be direct or indirect relationship in between ART clinic and ART bank. But to our great surprise, when we received the online form for application, in that it was clearly mentioned that ART clinic itself can register as ART bank also. So now the same gynecologist who is running ART clinic can register ART bank in the same premises on the same name. So what is the meaning of independent entity now? is not clear. So whether in your hospital, the ART bank premises should be separate, or staff should be separate, or instrument should be separate, nothing is clear. So it is needed to be clear by the government. Regarding sourcing of gametes, see, we are always in dilemma. It is mentioned that an ART bank can supply gametes of one donor to one commissioning couple only. Now, what does it mean? It means that an ART bank means एक ART bank एक डोनर के गैमेट्स को एक कमिश्निंग कपल को दे सकता है. Does it mean that other ART bank can give the sperm of the same donor to another commissioning couple? Answer is yes, because there is no clarity in regard to oocyte donor. Although it is clearly mentioned that oocyte donor can donate only once in a lifetime, but no such words are used in regard to sperm donor. So, as per our interpretation, sperm donor can donate in different ART bank, and those ART bank can supply the sperm of that donor to another commissioning couple. That may be interpreted. So there are always in difference of interpretation regarding oocyte donor. Again, we all know that one illogical clause was put in ART Act, which said that you can retrieve only 7 oocyte from the oocyte donor. Now, it was there was hue and cry in the fraternity, ART fraternity, that how can it be possible? We cannot leave oocytes in our body. It may lead to OHSS or some other complication. So it was heard, and they came out with the gazette. And in that gazette, it was mentioned that, okay, you can retrieve whatever amount of oocytes are developed. You can retrieve all of them at the time of oocyte retrieval. But still, there is no clarity that whether you can use all oocyte in making embryo, or whether you should use only 7 oocyte for making embryo. So still clarity is needed. Even after that gazette, they could not clear exactly what they want to convey. Regarding international donor, we all know that in ART Act, there is no prohibition of treating any international patient. Now, suppose you receive one patient from China. Now, Chinese patient and that patient is in need of ODC. So, oocyte is to be taken from the donor. Now, Chinese person cannot use Asian donor because their society will not accept Asian look in China. So they will always ask for a donor from the China. Now, as we all know that there is provision that now donor should be Aadhaar linked. Now, international donor may not have Aadhaar card. So how will you recruit international donor? What is the procedure of recruiting international donor? Whether it is allowed or prohibited, nothing is clear in this act. So till any clarity comes, as such, there is no prohibition of taking international donor. We always guide that you can take passport and visa of the oocyte donor. The donor should come on medical visa, and then you can do an oocyte pickup following all the guidelines of ART Act, except Aadhaar card. In place of Aadhaar card, you should take passport and visa copy.
No,
It
sir.
is honor that you are here.
Yes. It's a pleasure and honor to have you. We all know sir is President FOGSI at present, and we know sir as a very soft-spoken, intelligent, witty person. And sir is not just President FOGSI, but Chair YGAA Committee A of FOG, Project Lead FOGSI, US Aid Projects 2024, Secretary General Federation of FOGSI, and from 2018 to 2021, awarded the FRCOG Honoria Causa, maybe I'm pronouncing well, by the Royal College of Obstetrician and Gynecologists, and past president Mumbai OG Society. We all know. Sir, CV is so long that it will take, I think, 15-20 minutes for me to read. But we all know sir has done very, very important work in the field of MTP, in the law, and a lot for all of us FOGSians to make the in the amendment of MTP law also, sir has a very pivotal role. So, sir, we are all honored to have you here today. And sir, can you please say a few words to encourage us all?
Thank you. Thank you very much, Bela. Sorry again, Gitendra, for interrupting. Bela messaged me. I thought you have already finished your talk. That's why I joined. I had joined earlier and I left because you were speaking. Congratulations, Bela, for putting this very important webinar together on filling the lacunae. And of course, synergies and collaborations are important. So it's delightful that you're doing this along with the Rewari Obs Gyn Society, supported by the IFS Haryana chapter. Let me acknowledge the Secretary General of FOGSI, Dr. Madhuri Patel, and the Vice President for your committee, Girija, and the guest of honor, Dr. Charmila, and convener, Dr. Seema Mittal, whom I had the pleasure of meeting when I was in Rewari recently, I think around a couple of years back. And of course, it's a very good webinar, Bela, that you put together on the role of Doppler in obstetrics, ART Act from the master himself, Dr. Gitendra Sharma, and of course, important chairpersons, Dr. Asha Jain, Dr. Reshmi, Dr. Sunil, and Dr. Alka Yadav, madam, again, whom I had the pleasure of meeting at Rewari. And that's going to be followed by a panel moderated by Dr. Seema and Dr. Anubhuti, with panelists Dr. Sonu, Dr. Reema, Dr. Pooja, and Dr. Neeru. Keep it up, and we hope to see many more great things from you. Thank you.
It's just possible because of support and encouragement from president like you, sir. So thank you so much for always encouraging all of us to do whatever academic activity we want to do and for supporting in every way possible. So thank you so much, sir, for joining even from your busy schedule and the various parallel webinars and activities going on. So for sparing your time and being with all of us and blessing us. Thank you so much.
So we were with international donor. So as we all know that there is no clarity in regard to international donor, how to recruit them, what procedure should be followed by ART bank. And till date, any Aadhaar link will come. Till then, we should continue doing it with the passport and visa copy. But after that, what will be the situation? Nobody knows. And there is no answer till date. Can donor be compensated? Again, this is the question in our mind. See, we all know that in section 29 of ART Act, it is clearly mentioned that you cannot sell, you cannot transfer gametes without, or you cannot compensate even. So you cannot do sell or transfer or even information of the gametes to one person to another. So basically, as per Act, it is clear. The reason why it is clear as per our interpretation, previously in 2010 guideline, section 29, same section 29, it was saying that you cannot sell. But in that section 29 subsection 2 was the exception, and in which it was clearly mentioned that if you are using the gametes from the donor or helping any ART couple, commissioning couple, then you can compensate. It was mentioned in there. It was an exception. But now in new act, that exception is been removed. So now it is clear that the intention of government is to put that no compensation should be given. Even after this problem of interpretation, multiple RTIs were done by different people to clarify. And to my great surprise, every RTI got the different answer. In one RTI, it is said that you cannot compensate. In another RTI, we got an answer that you can give traveling and food allowance. Other things you cannot give. So these kind of information which we are receiving in RTI, and what will be the legal status of RTI is very difficult to understand, because RTI is a personal information given to a person, and it cannot be expected from a person to know the answers of all the RTI. So even if you are not following any command given by the authorities through RTI, definitely you are saved. You are not bound with the information given in the RTI. So as far as our interpretation is concerned, donor cannot be compensated, and every donor should be I can say the altruistic donor. It should be out of love and affection. The patient can donate out of love and affection to the relatives or to the friends, but they cannot be compensated on paper. And if we give any compensation to the donor and if it is proved, then you can be in the big problem. So also ART bank also cannot compensate a donor. Now, logically we can understand that no donor will ever donate without any kind of compensation. But still we have to follow the law. And as per law, in future, only altruistic donor means donor from the relatives or friends will be there. Otherwise, all other donors, professional donors won't be available. Regarding this transfer of gametes or embryos and own gametes from one place to another, it is mentioned in the act that even if you want to transfer your gametes or embryos from one ART clinic to another ART clinic for treatment, then you have to take permission from national board. And for taking the permission, different kinds of forms are being provided. That is form number 16 to 24. So the clinic which is transferring your gamete should also make an affidavit. The clinic who is taking charge of the gametes or embryos is also supposed to do affidavit, and you are also supposed to fill the proper form which is there according to the act itself. So again, it is mentioned that you have to take permission of national board. Now, where is the national board? To whom to communicate? How to communicate? Nothing is clear. And nothing is been, I can say the information is nowhere provided that to whom to contact national board. So these are all the things, I can say the flaws in the act itself. And it is very difficult to follow this act. If you go through the list of offenses, it is mentioned that if you exploit the commissioning couple, woman or donor, then it will be considered as a crime. Now, what is the definition of exploitation? Nowhere mentioned. What is the meaning of exploit? It is not clear. So now exploit word will be defined or will be interpreted by different people in a different way. So that means it will be on the discretion of court to punish you. So even if you have told the patient that I will take 1 lakh rupees for one cycle, and if you have taken 1 lakh 10,000, then whether it will amount to exploitation, it is not clear. So what is exploitation is not been defined. And for exploiting the commissioning couple, woman or donor, the punishment is 5 to 10 lakhs rupees fine for the first offense and 3 to 8 years imprisonment for the subsequent offense. It is something illogical and unacceptable. It is also mentioned that if you use any intermediate to obtain or purchase gamete donor, then it will also be considered crime. Now tell me how ART bank will screen a donor. Donor will directly never come to ART bank. Some intermediate is required. You may or may not pay that intermediate, but without intermediate, somebody cannot come directly to ART bank to donate. So what is the exact interpretation of this intermediate person or tout or this I can't understand, and how it will be interpreted in future against our fraternity members. This is surprising. So many things are not been answered in the act. Who is a gynecologist? See, again, in the act itself, when you go to ART level 1, it is mentioned that for a gynecologist to start ART level 1, the definition of gynecologist should be the definition which is given in PCPNDT Act. Now, if you go to PCPNDT Act, it is clearly mentioned in that act that gynecologist means whoever has any postgraduate qualification and who should be registered in state medical register. That is the definition. Now, postgraduate qualification means what? Postgraduate qualification means it can be postgraduate diploma, it can be postgraduate degree. But if you go to the definition in this ART Act, again at a different place, it is mentioned that for starting ART level 1, the definition of PCPNDT Act is okay. But for starting ART level 2 clinic, it is mentioned that the person should have postgraduate degree in gynecology. Now, whether degree contains diploma or not, it is not clear. And in many of the cities in India where registration was done, in that DGO persons were denied to be registered to start ART clinic level 2. Although it should not be done. So, surprisingly, experience of a gynecologist. See, suppose you are MD Gynec, and if you want to start ART level 2 clinic, then it is mentioned that even a postgraduate doctor should have 3 years experience in ART. Okay. And for super specialist also, see, suppose somebody has done FNB after completing MD in obstet and gynec for 2 years in infertility. And if he's a super specialist, so the experience for super specialist is also 3 years. Surprisingly, one gynecologist from Bombay, who was super specialist, FNB in infertility, she had come for registration to one appropriate authority in Mumbai. That authority asked her that what is your experience after FNB? So she said, my experience is 1.5 years after completing FNB. So that appropriate authority denied her to register for as an ART clinic level 2. He said that 3 years experience is must, so you cannot be registered. So she came to us that, sir, what we should do now? So I said that why you are telling that appropriate authority that you are super specialist? Tell him that I am MD Gynec with 3.5 year experience. Then he will register. So again she went. She did not divulge that she is super specialist. She said that I am MD with 3.5 year experience, and he registered her for ART level clinic 2. So these kind of illogical things are there in the ART Act. And it is surprising and illogical things which are there. Again, to be registered as an embryologist, it is mentioned that embryologist should be graduate or postgraduate in life sciences. Now, many appropriate authorities are considering veterinary science as a life science, but they do not consider MBBS as a degree of life science. They said that biotechnology, some bio word should be there. And in medical degree, bio word is not there. So we cannot consider you as a life science graduate. And MBBS doctor were denied to be considered as embryologist, while veterinary doctors were registered as an embryologist. It is great surprise to me that these kind of laws are there in the India, in our country. So dear friends, over and above these kind of this, I have mentioned only these 15 things because there was a limited time. But I can quote minimum 100 discrepancies in this act, different act. So there is no uniformity in implementation. The reason is there is discrepancy in act itself. There is discrepancy in interpretation. There is no training given to appropriate authorities. So lack of training and non-appointment, even appropriate authorities are not appointed at certain places, even after passage of 2 years of enactment of this act. So haphazard implementation of ART Act and rules has been done by different state. See, I can quote thousands of examples where in Tamil Nadu, somebody said that one committee said that Tamil Nadu government committee meeting was held, and it was said that nobody can start ART bank. Only NGOs can start ART bank. Now, nothing is written in this regard in the act that only NGOs can start. So that kind, and no other person should be allowed to start ART bank. So these kind of fatwas, I can say, are now coming from appropriate authorities, and poor gynecologist or ART specialist will have to follow these fatwas, same like PCPNDT Act. So this will be another PCPNDT Act. vast powers are given to appropriate authority, and I can 100% sure, I am 100% sure that avenue of corruption have started and will continue to remain in this field. So, dear friends, I can only say that before this act, 2005 guidelines were there, 2010 bills were there, 2014 and 17 bill were there. I can 100% sure and tell with guarantee that all were better than this ART Act and rules. All guidelines were better than this act. I always say that government has come out, have given birth to a premature baby. So ART Act is been enacted prematurely with too many flaws in it. So government has given birth to a premature child, and now government is trying to come out with different gazettes. That means they are trying to give injection surfactant to premature baby to keep it live. So, dear friends, this is the update of Tamil Nadu meeting, which I was telling. So, dear friends, I always show this slide, and this is very near to my heart. I feel this picture is a reflection of the mindset of our profession. Sooner or later, we all will sink if we don't unite and take decisive remedies. Please, please, please get united and represent your fraternity with might. We all know that one new thing has come in new IPC, that is Bharatiya Nyaya Sanhita, and government had put one clause of accident. They had increased the punishment for accident person who flee away from the place from 2 years to 5 years. Immediately, all transport members objected and went on strike. And within 2 hours of the strike, the government announced that we are taking back our decision of amending this particular section 304A. So, dear friends, if you are united, you will be heard. If you are not united, nobody is going to hear you. Always, I end my lecture by saying that there are always difficulties in all the professions. So, सफर में धूप तो होगी, चल सको तो चलो. कांटे भी होंगे, कंकर भी होंगे, चल सको तो चलो. Means there will be difficulties in practice, medicine. ये फूलों की सेज नहीं. So nowadays, after enactment of these many act, MTP Act, PCP, NDT Act, ART Act, other acts, ये फूलों की सेज नहीं, धधकता लावा है. चल सको तो चलो, otherwise leave your practice and become a lawyer like me. Thank you very much.
Over to Brigadier Sunil Takia sir to conclude the session.
We were listening with great awe and respect, Dr. Gitendra Sharma. It's been fantastic listening to you, that you have been providing clarity on such unclear issues. We wish we are all there together forever so that we can look after the interests of our own kith and kin and the interests of the patient. A very nice deliberation, Dr. Sharma. Thank you so much.
This was more than perfect, sir. You just talked my heart out, and I really don't know. It's just 360 turn again. And sir, we would request you to stay. We have certain questions which we framed for our worthy panel.
The only question I wanted to ask, that you were talking about altruistic donors. So many patients, they come with their relatives to be used as for donating sperms or oocytes. We enroll them through ART bank. We can tell them to
100%
go.
yes.
Yes.
Okay, so how do we go ahead? We have to tell them to contact a ART bank, get themselves
Yes,
registered.
you can channelize them through ART bank. Directly, you cannot recruit. So if you have your own ART bank in your clinic registered, then you can directly recruit in ART bank. And if you do not have ART bank, then you can channelize them through some ART bank.
Very good
Okay,
question.
thank you, ma'am. And sir, the anonymous part which we always talk about will be gone with that case if we are using altruistic donors. So will that affect in future in any ways?
Madam, it will never affect. The reason I will give you. See, people, there, suppose in family there were 2 brothers. And one brother had 3 children, and another brother did not have any child. So they were adopting. Whole life,
Yes.
they were knowing that this child is not mine. And the other person was knowing. But legally, that child is going to get all the rights from the parent who is adopted, and not getting any right from the parent who have given the person in adoption. So if your paperwork is clear, if somebody has legally donated and somebody has legally accepted that donated gamete, then
Okay.
there is clarity in law that they cannot say that this is my child in future.
Okay.
Sir,
And
one-
sir,
Okay,
does
go ahead.
ART Bank need to go with any permission for using such altruistic donors? Or they can go ahead in the same manner as they're recruiting the donors?
Madam, there is no permission required.
Okay. Thank you, sir. Thank you so much.
So one more question. Excellent deliberations, sir. We really very much benefited with your presentation. One thing is that about gynecologists. So any DGO, if they are not done DNB, they can register as a gynecologist.
Why not, madam?
Yes.
So any post graduation.
Yes.
Okay. Fine.
Sir, one more question. For sperm donor also, how many times a person can donate sperm?
Madam, regarding sperm donor, see, regarding oocyte donor, it is clearly mentioned that oocyte donor can donate only in once in a lifetime. But in sperm donor, no such clause is been put that he can donate only once in a lifetime. And the word used is that an ART bank can provide gamete of a donor, not more to only one commissioning couple. So that means one ART bank can provide to one couple. So another ART bank can definitely provide the sperm donor of the same sperm to the another commissioning couple. And it is nowhere mentioned in the act that sperm donor cannot donate more than once.
Dr. Niru, what are the areas that you feel need amendment in this act? Your ideas. After listening to sir, I think we all are wise enough. But I just want your personal views. Yes.
I just want to ask Dr. Gitender, like the age limit. So 21 years only, it is only that IVF we cannot do before that age. Otherwise, if a patient wants some follicular monitoring or ovulation induction, everything can be done. But
yes.
Still, our clinic does not register those patients.
No, you can register, you can time the coitus, you can do follicular study, you can stimulate ovaries, everything can be done. Only ART cannot be done.
IUI and IUF.
IUI is an ART. So IUI and other ART procedures cannot be done before 21 years, completion of 21 years.
Okay, and what Dr. Reema was asking, like we have been recruiting the known sperm donor and the oocyte donor through the ART bank. All the paperwork and everything is done, and then they are taken up. We've been doing this since started the program.
Right. So, Dr.
Thank you,
Niru.
Dr. Sonu.
Yeah. Hi, Seema. Thank you. This ART bill is very good for channelize everything to control all the ART procedure, ART center. That's a very good thing government has done. But still we need few amendment in this act, as sir has already told. First most is that 7 oocytes. They said we should retrieve 7 oocyte. However, all forms should be retrieved. But from 7 oocyte, if patient is spending so much money on the donor nowadays, insurance, affidavit, donor, anything, everything, and from 7 oocyte, M2 are suppose 5 only. So they will get hardly 2 or 3 blasts or even 1 blast sometimes. So next cycle, poor patient has to pay whole money for the next cycle. And if they says we have to use 7, that means we are discarding that eggs. So it's poor for the patient, although government is thinking everything good way to channelize the center, but this point goes in disfavor of the all poor people that they have to spend next time. And anywhere, nowhere, the result is, we say, yes, they will conceive. Result is 50%, 50%. So we cannot say people will conceive.
But Dr. Niru, like now Dr. Gitender was also saying, we can extract all the eggs and
but
maybe
we cannot use
only 7 M2 from them and then do it.
Gitender sir.
Right,
Yes.
Dr. Gitender?
They said 7 oocyte. They have not used that is not clarity. No? They have not used any word M1, M2, anything. They have used 7 oocyte to be taken.
So you may use
the
the best out of 7, best 7 out of them.
We can extract all, but you use the best out of all of them. Use the best 7 out of them.
But after
So rest have to be discarded,
also
ma'am.
sometimes we don't get so many blastocysts.
Yes,
patients
madam.
should
You have to discard rest.
All
discard
others
rest.
Okay.
should be discarded.
Either you have to discard or you have to manipulate each word according to your convenience. Is it
No,
that,
no,
sir?
no, no. You
No,
have
doctor,
to.
no manipulation in this.
So you
Sir,
have
do
to
we
discard.
need to document then that we are discarding so many
Yes,
oocytes
there
or
is-
Yes, yes.
okay.
that's very painful. Sir, can we make some amendment? Can we tell the lawmakers not to do this? Are there no females in the group, in the coliseum of?
Madam, multiple doctors, gynecologists were there in the committee, but
How could they?
surprisingly, even their opinion was not taken before framing the act. Dr.
That is-
Kamini Rao was there, Dr. Manish Banker was there in the team. Multiple gynecologists were included as a member in the committee which drafted this act. But it is said that they have drafted, but their opinion was never taken as per them.
So painful. It's like, throwing your gold out of your house and it is a compulsion that it should be thrown. So,
So
like,
that's why Dr. Jitendra is saying we should unite, we should write, we should say, maybe government listen to us.
But I don't know if I'm
All people only, they have done so much. Maybe they do so something more also. And secondly, like single woman, widow, unmarried can go for surrogacy at the age of 35 to 45 years. At that age, for surrogacy, they have to use definitely their own eggs. After the age of 40, how many eggs will be there?
Dr. Sonu, you're saying something?
Dr. Jitendra?
Yeah. So
I
in
just
surrogacy now, madam,
Like
it
in
is.
age limit, they cannot go for surrogacy at 32. They cannot go for 33. After
Madam, now in
33,
surrogacy with new gazette, it is now clarified that self gametes are not necessary, first of all.
no, but
So
single
No, sir.
women, they have to be now
for single woman, yes, oocyte should be the
Yeah,
woman's.
for I'm asking for a single woman, widow woman, unmarried woman.
Yes,
So they can go only after the age of 35. They have to take their own eggs.
yes, yes.
That's age should be, I think, relaxed after 30. And thirdly, the point which you have also said very well, that intermediate person. Definitely all these ART banks, they are taking eggs or oocyte from the intermediate person only. So how can they do without them also? And thirdly, the ovum donor can donate once in a lifetime. After some time, there will be definitely shortage of the donor.
Madam, there no shortage. Actually, no donor is allowed to second time only because that donor should always be altruistic and from your friend and from relatives. So if people will start coming with their own donors, then there will not be any need of professional donor. So
friends,
what you are telling that
meeting.
professional donors will not be available. So definitely government want to restrict them or to prohibit the professional donors.
It's
But
like kidney
Sir, should we
donation.
counsel the
everyone
patients to
is
get their
knowing
own donors?
मैडम
Sir,
जब
should
चीज
we
मिली
go?
बाजार मैडम जब आप 5 लाख या 10 लाख खर्च के बाजार में चीज मिलती है ना तो एवरीबडी लाइक्स टू स्पेंड दैट 5 lakhs or 10 lakhs but avoid divulging their diseases to their relatives. But when these kind of laws come, then there is no alternative to them. Now people will come forward and start divulging their disease to their relatives, discussing their disease with their relatives and request their relatives to donate for them. Same like kidney donor.
Oh,
See,
sir,
kidney
but then
donor
poor
में
daughter-in-law,
relative
all mother-in-law will force the other daughter-in-law. You have to give eggs for your younger daughter-in-law. That problem will come later in the life.
that
They
may
will
come.
force others that you have to do for my daughter-in-law. They will force.
nobody listens.
Madam,
But this
madam, जब law बनते हैं ना,
It's a
law,
India. It's a India, sir.
madam, when laws are framed, see, this it is said that law is an instrument of social engineering. So whenever some fault is there in the society, to correct that fault, these law are been enacted.
Right.
Now second thing, when laws are made and later on it is found that this is misused, then they are also changed. 498A was put to protect the woman from the dowry. Okay. Now it was excessively misused. That particular section was excessively misused by the female. Every woman was telling, अगर छोटा मोटा घर में झगड़ा हो जाए तो मेरे से दहेज मांगा और सास ससुर सब जेल में चले जाते थे.
अब सास ससुर फोर्स करेगी कि आपको एग देना है
So
दूसरी
it
बहू
was
को.
misused and it was misused now. So अब गवर्नमेंट को पता लगा कि ये बहुत मिसयूज हो रहा है तो they have put a break on it. they have mentioned that no arrest should be done directly.
So
But
that will happen in the case as Dr. Neeru is saying, if
हाँ,
Yes.
इस समय
the
बड़ी बहू को
pressure from the
बोलते हैं
family
कि
will
छोटे
come.
के लिए एक दो, अब
Yes,
आपका
yes.
बच्चा हो गया, आप दो दूसरे के लिए.
So change will come because see, I can quote that multiple cases are being filed in Kerala High Court and even Supreme Court. And Kerala High Court, in multiple cases, judges have categorically mentioned that certain clauses are not, I can say, perfect. So in one, I'm giving example, they have given in judgment that a woman who is continuing the treatment since 45 or 48 years, she should be allowed to continue taking treatment even after the 50 years. That kind of judgment has come. Second, this judgment, we all know this amendment has come only after the judgment of Supreme Court that donor oocyte and donor sperm should be allowed in surrogacy.
Yeah,
So,
definitely. They will definitely
even
do
in one of
something
the
for
judgment by
it. They
Kerala High
already
Court,
realized.
it is
Yeah.
said that transfer of embryo or gamete for own use, there should not be any permission from national board. It is illogical. So these kind of things will definitely come. So some illogical sections are there in the act. If they will be challenged properly in a proper court, High Court or Supreme Court, definitely we are going to get good results out of it.
And so these ART bank, they are not taking donor without monetary benefit. They are doing not
Yes.
from the directly, they are doing from indirectly and thing.
नहीं, अगर पकड़े जाएंगे तो डायरेक्टली या इनडायरेक्टली कुछ भी लिया होगा तो जेल में जाएंगे.
हमें तो बैंक से लेनी है
तो
हमारे लिए.
सर फिर हमें तो बैंक से ही लेना होता है. तो if any
How
patient
they are
goes and complain, how will we deal that?
That's why we always tell that you should not involve yourself in financial transaction.
Yeah,
Okay.
that's true.
Let ART bank do whatever they want.
So
Don't
one query, one
see,
query
most
more.
of the ART clinic, what they are doing, they are taking as a package from the patient. हमारा 2 लाख का पैकेज है, उसमें 50,000 डोनर का है, and they give 35,000 to the ART bank. So they become the part of the financial transaction from the commissioning couple to ART bank. And if you will do that, then you will also be in problem. So to avoid this, you should not become the part and parcel of any financial transaction in between ART bank and commissioning couple. Let them do whatever they want, so you will be safe.
Secondly, sir, regarding ART1 clinic, many gynec, they ask like those who are doing IUI or those who are handling the gamete, they only have to register for IUI, or those they are stimulating for gonadotropin for the IVF for the they also have to register.
Madam, stimulation do not want any registration.
Okay.
Only and only ART procedure if you want to do IUI or any IVF or ICSI or whatever it is, then only you need registration. If you want to do only IUI, then ART level 1. If you want to do IVF and IUI all, then ART level 2.
Yeah, it was clear in the act also, but in some webinar,
See, many guys, now that is wrong thing which has been promoted by many people. Gonadotropins cannot be given by
gonadotropins,
gynecology.
that
It is
was
not like that.
overheard in a webinar. That's
Anybody can give gonadotropin, anybody can rupture the follicle by giving HCG in their own clinic and time the coitus. For time the coitus, you can stimulate. But for ART level 2, for IVF procedure, you cannot stimulate.
So then I feel we go other way around. We just ask you questions and you answer, because nowadays so many we see board, say from XYZ hospital, IVF center, and they are just putting their boards in small towns. Is it permissible by law?
Not at all. Not at all. Yeah, they have to register even the place, which is, if they are doing IUI there, then they have to.
No, they are just picking up patients from there, not doing anything. So do they have to register?
They are doing OPD like
not at all. If they want to do IUI or ART, then only they are supposed to register.
But
Otherwise,
for OPD also people are registering in our town.
It is not required at all. That is misinterpretation of the act.
Okay. So,
also one doubt I have.
Pooja,
one more query, sir. If someone wants to change the name of the center, and after giving initial application, same owner, same place, only the name of the center.
Madam, ART Act has no provision in regard to this change of name. So same owner, same management, same place, everything is same. Even then, if your name is changed, they ask you to for separate registration. Fresh registration.
Why 2 lakh rupees for registration, sir?
Yes.
Why 2 lakh means it could be 2,000 also, sir.
That you can ask government. And if you unite, it can be reduced. But you didn't unite. You were ready to pay 5 lakhs even.
How to unite, sir? Please tell some.
Madam, truck wale kaise unite हुए?
They have less of brain, sir. We need to remove some gray matter. Then only we
ताकत है
can
तो
unite.
आप 1 महीने के लिए हॉस्पिटल बंद कर दो, सरकार आपके चरणों में आ जाएगी. ताकत है डॉक्टरों में?
1 घंटा भी नहीं है, सर.
हाँ, तो फिर नहीं है ताकत.
So for surrogacy, you can tell in any instructions to us directly what you want to give, all of us.
Surrogacy is one of the best acts, I can say, in favor of doctors, gynecologists, because there is no responsibility on the head of a gynecologist. Because appropriate authority will provide eligibility certificate to commissioning couple. Appropriate authority will provide the eligibility certificate to surrogate. Then essentiality certificate after verification of birth affidavit and after verification of insurance and medical indication certificate, then appropriate authority will issue the essentiality certificate. So the role of gynecologist will only one, that once patient will come with all these 3 certificates, then you can start the treatment of surrogate.
Yeah,
it's very difficult now, so then it's almost impossible type of thing.
But it is very easy for gynecologists now. You are not responsible anywhere. If the certificates will be found wrong, the appropriate authority will be held responsible. So you will be safe at least.
But
Or
sir,
maybe
they have
No need
patients.
to send to lawyer, just send to appropriate authority, get all these 3 details, and then we can do.
Dr. Sonu, yes.
Yeah,
And how
doctor.
long does it take typically for this procedure for a patient to get all these 3 certificates?
Madam, there are forms available for getting eligibility certificate from appropriate authority. They have to fill that form. They have to affix whatever annexer, whatever documents are required as per that form to confirm that they are as per they are following rather, or they are fulfilling the requirements. For surrogate, we all know that requirement is that the age of surrogate should be in between 25 to 35. She should be married. She should have 1 child. So whichever she should be only once she can become surrogate. So these all things will be confirmed by appropriate authority. Then same thing, commissioning couple will also have to fill the form, and in that form annexers will be there. In annexers, they will confirm that the age of the female should be in between 23 to 50. The age of male should be in between 26 to 55. They should not have any child. And if any child which is mentally retarded, they can definitely give permission to them. They should be Indian citizen or at least person of Indian origin. So whatever requirements are there, then they will confirm that they are fulfilling the requirements. Only after that, they will give the eligibility certificate to the commissioning couple.
It must be taking 1.5 to 2 years to get all this done, sir.
Madam, people are getting it in within 15 days now.
That's nice.
The procedure has to make, see, SOPs should come out. And see, in Calcutta, people are getting all the certificate within 1 month. And they are starting treatment within 1 month of any surrogate. So once the procedure will be streamlined, it will be very easy. The problem in northern state that the advocates are exploiting now the doctors, because doctors are interested more in surrogacy treatment. Why they only can answer?
Dr. Sharma, if I can chip in slightly over here, this is something like a driving license. Driving license is obtained online. Only thing is that there are touts available and agents available.
Yes.
We are entertaining a culture in our country.
Yes.
Regret, but
Yes.
that's a fact.
Yes. I agree. 100% I agree, sir.
Dr. Sonu wanted to say something since long. Dr.
Sir,
Sonu,
I have heard that in Delhi, advocates had taken 8 lakhs to 10 lakhs rupees to get all these certificates. And even
And
after taking 10 lakh
and
rupees, they
advocates
take
never have to declare
6
their
months
income.
to 1 year.
Never.
And even then, doctors are entertaining those advocates.
Thank you, sir.
Dr. Sonu, yes.
No, I was just asking like how to exactly go, like if a couple is for surrogacy, so they have to go and meet like we have to get the certificates made, or who has to get they only have to get the certificates made.
मैडम,
And
डॉक्टर को कुछ नहीं करना है.
फॉर्म फिल
डॉक्टर
करके
के
देना
पास
है, एक के पास भेजना है.
first ART commissioning couple will come to you. You have to examine couple. You have to give certificate in writing that this patient needs surrogacy treatment due to this reason. Now, with your certificate and with your case paper, the commissioning couple will go to appropriate authority. Appropriate authority will refer that patient to district medical board. District medical board will issue medical indication certificate after going through your papers. And if they need some other investigations to be done, they may ask a commissioning couple to undergo those investigation. They will issue first medical indication certificate. Now, after getting medical indication certificate, the appropriate authority will tell commissioning couple that select your surrogate. And after selecting your surrogate, you should go to ART clinic.
I would like to interrupt Dr. Gitender. So who is the appropriate authority and the medical board if we don't have in our state? So where should the
High Court में जाओ, आपके यहाँ नहीं है तो.
That's what I wanted to.
Most of the states, they have now appropriate authorities, and they have started working. See, in Punjab also they are working. In Gujarat also they have started working, and in many Calcutta was the first. Even West Bengal was the first who started regularly doing that. So only UP, Bihar, and some part of Gujarat and Maharashtra are lacking behind.
It's same PNDT committee which is coming for ultrasound. They in Rewari, it's same PNDT committee. So
There
I
may be
suppose
same and there may be different.
Right, sir.
So then patient will come with surrogate, okay, to ART clinic first. ART clinic will give medical certificate and psychological fitness certificate to the surrogate. So you will see that endometrial thickness of surrogate is okay or not, psychologically she is fit or not. So you will issue psychological and medical fitness certificate to surrogate. After getting that certificate, surrogate and commissioning couple once again will go to appropriate authority for getting eligibility certificates. So they will fill the form, they will attach whatever is demanded by them, and they will be issued eligibility certificates. So दोनों को जब eligibility certificate मिल जाएगा, after that commissioning couple will take 36 months insurance in the name of surrogate. And last but not least, that birth affidavit. So for that, they will appoint one lawyer. They will have to proceed to Metropolitan Court Magistrate, and they will get a birth affidavit certificate from the or parental order, what is said. So they will get parental order from the court. So once they get parental order, so with parental order, 3-year insurance and medical certificate, they will again go to appropriate authority, and going through all three certificates, appropriate authority will issue essentiality certificate. Now with 2 eligibility and 1 essentiality certificate, patient with surrogate will come to ART clinic and you will start treatment of surrogate.
Okay.
Sir, in Haryana, we have board is there. Inspection has been started. Surrogacy, even though is not started. So appropriate authority will be CMO, or it will be appointed one person. They will appoint someone.
Madam, in law, it is said that it is to be appointed by government. So government may give this authority to CMO. Somewhere government may give this authority to collector. Somewhere they may give it to somebody else. So it is up to government.
Okay, so they will decide.
Yes.
So thank you, sir. I don't.
Dr. Seema, I'm so sorry.
Yeah, everybody has to leave, I think, sir. But whatever the appropriate authority might be, you were the most appropriate person to discuss this subject with. Thank you, sirs. Thank you so much for your valuable time. And Dr. Sonu, you can conclude the session.
Thank you so much, Dr. Dipender. And thank you so much, dear esteemed colleagues and panelists, for this wonderful session. Dr. Reema, Dr. Neeru, it was a wonderful learning session, Sonu ma'am. And I'm sure we are all coming out really enriched. Thank you, Dr. Seema, for organizing this wonderful webinar for all of us. Really a learning experience.
And
Thank you,
we
ma'am.
sincerely thank Dr. Bela Bhatt, Dr.
Yeah,
Asha, and
Dr.
Dr.
Bela,
Reshmi for this wonderful session. Our President FOGSI, Dr. Jaideep Tag sir, for his valuable and precious time, and team Jagsonpal for supporting us and making us wiser day by day. Thank you, one and all, Dr. Alka Yadav, Dr. Anbhuti, Dr. Brigadier Sunil Takyar sir, who's there always unconditionally, and he has such important inputs. So we thank you all our chairpersons.
I will also like to pay my regards to Dr. Sunil Takyar, Dr. Asha Jain madam, Neeru Thakral madam, and Sonu Balara madam, and all who are present today in this webinar. So thank you.
Thank you, sir.
Opportunity.
And thank you, Bela ma'am,
It
for
was
the
nice
wonderful talk
Seema
today.
Mittal
interacting with
and
you.
Bela madam.
It was nice interacting with
Thank
you.
you.
Thank you
Thank
so
you,
much,
Sunil sir.
Dr. Gitendra Sharma, Dr. Seema, Dr. Alka, Dr. Anubhuti, all the panelists, Sunil sir, who's always there in all the webinars. Thank you so much, each and everyone, from core of my heart for making this so informative and so a good webinar for all of us to learn a lot. Dr. Seema, wish that you continue with such a series of webinars for all of us so that we keep enjoying the academics to the most.
For us, Dr. Bela, these are like Allen online classes. So we get, the best faculty and the best notes. So it's so easy. Life is very easy for us, and we really enjoy. And thank you so much for all the precious time. And may I request Deepika ji, she wanted to speak something on behalf of Jagsonpal. Thank you so much. Dr. Deepika, thank you so much for all the hard work that you put in for our webinars.
Thank you very much to all the experts and the attendees. Here there is a small little video that we play